Hi everyone. I did the question on ethylene glycol, question 9 for 18 marks. Um, we'll go through that now. So I divided this question into sort of four gradual parts. Part 1 was interpretation for the blood gas. The question was to list four findings with associated calculations if needed from the above results that are suggestive of ethylene glycol toxicity. So for 4 marks, a lot of people interpreted this to mean that I should calculate everything that's available to me, but the idea was to actually purely put out results that are suggestive of ethylene glycol toxicity. So what we were looking for was a HAGMA with some calculations would be nice, and to comment on the elevated osmolar gap, and elevated lactate, and the raised creatinine with acute renal failure. So these are the sort of findings that would suggest ethylene glycol toxicity. The marks lost here were purely people writing HAGMA plus an osmolar gap, and sometimes calculating the osmolarity, but not actually telling us that there was a gap there. And other findings, a lot of people calculated the CO2 instead. So that's where a lot of marks were lost. The next, so the second question was list two further findings on other investigations that, if elevated or abnormal, are pathognomic for ethylene glycol toxicity for 2 marks. So a lot of people here mentioned features that I wanted you to mention in the previous question, like elevated lactate, respiratory acidosis, but those are not really pathognomic. Pathognomic means characteristic for that condition, the presence of which means 100% this is that toxicity. So the answer here is hypocalcemia, as well as calcium oxalate crystals on urine microscopy, and this is found in all of your resources. So again, reading the question is very important, and that's where a lot of people lost their marks here. Was another bit of a mixture of a table. The idea was to complete the table for the 3 stages of ethylene glycol toxicity. You'll find this table in most of your resources, so it's an important question for me to ask. The initial few hours is pretty much how you would see someone who's drunk. So ataxia, slurred speech, and drowsiness. Drowsiness doesn't mean decreased GCS in those sort of features, but I accepted that as someone did comment on that, which is fine. The next time period will be 6 to 24 hours, and I accepted if people put in a specific time frame within that broad category as well, rather than being very prescriptive. So in this sort of stage would be HAGMA, tachypnea, tachycardia, hypertension, and of course a decreasing GCS, significantly decreasing GCS. The period after 24 hours, and I accepted even longer than that if people mentioned neuropathies, so which was fine by me, but what we were really looking for was progressive worsening acidosis, renal failure, hypocalcemia, seizures, coma, like that type of thing. So a bit of a gradient in the different features. The marks lost here were mainly areas where people didn't have any obvious timeline, and some people put in clinical features in every single box, which was clearly not what we were asking for. The final question was to state 6 steps in the management of this patient, assuming the patient is already in a resus cubicle with IV access and physiological monitoring attached. We were really looking for a stepwise management of a gradual escalation of care, which would be intubation for airway protection and hyperventilation. I accepted any sensible plan with drugs and doses here, and that was, I think, a very common answer for a lot of people, which is fine. Sodium bicarb to correct pH to 7.3 with dose, as well as correcting any electrolyte abnormalities and hypoglycemia. Also, as part of this question, you are meant to discuss any antidotes. So commencing ethanol via nasogastric tube, and I accepted IV dosing here as well, as long as you had the correct parameters and concentrations mentioned. A lot of people made mistakes with IV dosing in this. Also, a lot of people mentioned fomepizole with the loading dose, which was nice to see. But a lot of people missed out pyridoxine or thiamine as adjuncts, so that's where a lot of people lost marks. ICU admission was mentioned, but I wanted you to sort of say why. ICU admission is not a treatment plan or a management step. It's for monitoring and ongoing care. So would like you to mention hemodialysis. That's the reason why they're going up to ICU and because they're intubated. Similarly, in the next slide, we'll talk about what other sort of comments people made as well. So in terms of comments, I would like to say that I did not accept toxicologist consult as a answer for the STEM unless you qualified it with a specific question or therapy, such as for consideration of additional antidotes or adjuncts. Also, I accepted answers that included techniques for warming and IV fluids, both to targets. And the next question we'll talk about the range of marks. The range of marks, there was a broad range between 3 to 17, and the top marks reflected the answer scheme and were in correct order. Low scores associated with blank answers and minimal detail. Lower scores are also associated with not reading the question, putting down answers in the wrong stem, for example, and things like that. So thanks very much. Hope this was a good learning exercise for you guys.